Ahmed Al-Ayad. I am a PhD student at University of Maryland, Baltimore County. This research about, we have 5 minutes, I think? Okay. So this research about the adoption of home healthcare robot investigating the moderating effect of demographic characteristic. Actually, we are a group of researchers at the Information System Department, and this is like a part of our research. Our research is focusing on the home health care and the adapting and using of emerging technologies, such as the sensor and the robot. But for this study, we are focusing on the robot technology, and we are focusing on the demographic characteristic. So, among recent national efforts to control cost growth in healthcare is to refocus healthcare delivery system to be patient-centric. Home healthcare is considered one of the most effective initiative that's used in this context. We can define home healthcare as a system of care provided by a skilled practitioner to the patient in their home under the direction of the physician. Home healthcare has been undertaken broadly by the healthcare industry of the United States, not only to control the rising healthcare costs, but also to improve post-hospitalization healthcare quality and increase patient independence. So today it's impossible to consider this home healthcare initiative without health information technology. Home healthcare robots are one of the emerging technology that hold potential to make clinical information available at the right time and at the right place. So here are some examples about the home healthcare robots, as we can see in the picture. In the first picture, we have a robot called a remote presence robot. This kind of robot used to facilitate the communication between the patient at home and the medical professional. The second robot, as we can see, it's called a Paro robot. This kind of robot is used to help patients with cognitive disabilities and older people to improve their positive mood, make them happy, decrease the feeling of loneliness and stress. So most previous home healthcare research has focused on technology development and technical implementation with very limited discussion of the socio-technical, contextual, moderating, and other human factors. This lack of understanding of these factors is the main reason leading to the failure of more than 40% of the previous IT development, including the IT in the healthcare sector. Therefore, our research aims to fill this knowledge gap and enrich our understanding about the moderator impact on the adoption of the home healthcare robot, which is still unaddressed in the home healthcare robot literature. So to fill the knowledge gap, we adapt UT model and propose the following hypothesis. And this is, as we can see here in the figure, this is our research model. And here are a set of hypotheses. As we can see, the influence of performance expectancy on the intention or on the adoption is stronger for men and particularly for younger men. The influence of effort expectancy will be stronger for women, particularly older women. And the influence of the social influence will be stronger for women, particularly for older women and for those in the early stage of their experience. The influence of the facilitating condition will be stronger for older individual, particularly for those with increasing experience. The justification for the hypothesis development are included in our research paper. Given the time constraint, I cannot go over all these details. So the methodology, the participants were recruited from a list of home healthcare agencies on the East Coast. These home healthcare agencies offer nursing care, physical care, occupational care, and social services and hospice care. The participants include both home healthcare patient and medical professional. A data collection method for the research is a survey. We use both online survey and paper-based survey. Survey instruments were refined through two pilot studies. Different versions of the survey were developed and used depending on the target audience and user. So here are some of the results of the research. We have 108 out of 166 responses were valid and used for the analysis of the result. And the first table shows the demographic characteristic of the participant. As we can see, we have male, female, participant from different age distribution, participant from different educational background. We have patient and medical professional. The statistic of the results show that more than half of the participants have heard or seen some kind of robot technology. Some of the participants use some kind of robot technology. So the result of the hypothesis testing, all the research hypotheses were supported. We follow an approach suggested by one of the previous researchers, how we test these hypotheses. So H1, H2, H3, H4 were supported. Based on the result of the study, we developed a decision tree. This decision tree helped the designer to provide cost-effective design. So if the home healthcare agency, if the target audience of the home healthcare agency are like male and younger, then we suggest that our results show that performance expectancy is the most important factor. So the designer should focus on the different perspective of performance expectancy. Time out. So here is the conclusion, theoretical and practical implication. A question, comment. I know that.
What's your top conclusion?
Top conclusion. Top conclusion is what are the most important factors to focus on depending on the target audience for the home healthcare agency. For example, if the home healthcare agency, the target, the user, the domain of the user of the home healthcare agency are, for example, older women, we suggest that effort expectancy is the most important factor when this agency are coming to adapt the robot technology. They should focus on effort expectancy. They should develop a robot that is easy to use, require less mental effort. That's one of the major findings. Okay, thank you.
Good evening. My name is Yazan Alansur. I work with Professor Jivan from the same university, University of Colorado, Denver. And I also, one of the co-authors are Todd Trotman from Kaiser Permanente, Colorado. The title of the study is The Impact of Patient Portals on Patient Care, and the evidence came from diabetes patients. What are patient portals? Basically, and I'm trying to simplify here, there are websites that allow patients to access medical information. Also, it might be used as a vehicle to communicate with the provider. Book appointment, for example, and see an alert. Due to the many attributes that are related to patient portals, we're focusing on alerts in this study. In the figure below, you can see that patient portal, the patient accesses the patient portal, and you can see him or her in red. And then after that, they click on an alert posted by the provider. The patient either ignore that or go and conduct a diagnostic test. Doing that, the system will update the patient portal and close the alert. So what is the research question, what we're trying to focus on here? We're trying to see how the portal influences alert closure time. And we're focusing here on the clicks and the views by the patient and the existence of comorbid alerts. So you can see that the patient will access the portal by logging into the portal and then go to a page where the alerts are posted. The dependent variable here is the alert closure time. And what we're trying to see is how would the independent variable, which is clicks and views, and comorbid alert would impact the alert closure time. The first hypothesis is that clicks and views is negatively associated with alert closure time. More clicks and views means less time to close the alert. And the presence of comorbid alert would actually reduce that closure time. and also would have interaction with the clicks and views and have a complementary effect on it. The alert closure time are the number of days taken by the patient to close the alert, and clicks and views are the number of clicks and views that the patient did to access this alert page. Comorbid alerts are alerts that come from diseases related or coming from different diseases that comorbid with the current alert that we're studying, and that came from the medicine literature. The data that we collected came from Kaiser Permanente, the diabetes registry, and this diabetes registry were for Colorado. There was like almost above 166,000 patients. 2,000 of these patients were given the A1C alert that is our focal alert. 680 patients had not closed the alert, so we left with almost 1,500 patients, and that's our sample. Patient that accessed the portal, saw the page of the alerts, and closed the alert. These are the results. We can see that we have two models here. The first one is the direct effect model. We can find the results, or we found the results to be negative and significant, which is in clicks and views, it was negative and significant. That support H1, our first hypothesis, that clicks and views negatively associated with the closure time, and also comorbid alert. The presence of comorbid alert is negatively associated with it. And in the interaction model, we also find the interaction variable between clicks and views and comorbid alert to be negative and significant, while H1 and H2 holds. To sum the findings quickly, if there was only a focal alert present with no comorbid alerts, the patient will need 12 clicks and views, or 12 clicks and views will reduce that closure time by 1 day. If comorbid alert present or a presence of comorbid alerts, 3 clicks and views would reduce the time by 1 day. There are multiple implications about our findings, and time is up. So, in the U.S. now, in the U.S. healthcare, you find there's a tendency toward, or there's an advocacy about reducing the number of tests, and it's bad because of higher cost. Our studies show an interesting thing, that actually more tests might not be bad. It actually might prompt the patients to go and do the test, and that contributes to reducing the closure time and the amount of time the patient takes to do the diagnostic tests. I hope that this was interesting. I'm sorry I have limited time. Thank you so much.
Thank you, and actually I just graduated from Emory. Now I'm at the Northern Illinois University. And I just want to let you know that we had first snow last Saturday in Illinois. So today I'm going to talk about my current study on EHRs and intraoperability. This is a joint work with Jason Hockenberry, Kimberly Rask, and Edmund Becker at Emory University. So according to IT-enabled process innovation framework by Thomas Davenport, information technology improves the performance of organization through process innovation. And in this study, we consider an EHR system as a tool to innovate processes of healthcare. And under the process innovation framework, comparability of IT system plays a role to facilitate IT process innovation. Specifically, more comparable IT system may promote process innovation even more by ensuring better communication and coordination. And there are two scopes of comparability of health IT system. First, the comparability among EHR systems of different hospitals, which is called interoperability, and comparability of a system within a hospital, or intraoperability. And there have been a series of studies examining interoperability of health IT system, addressing questions such as how HIE affect abilities to share patient information and improve healthcare quality and outcome. And in this afternoon, we already had 3 great paper on the HIE. And also one of our keynote speaker, Kelly from ONC this morning, also emphasized the interoperability from policy perspective. But very few studies examine how interoperability influences health benefit, even though interoperability is also crucial, as Mel had mentioned with Ebola case in Texas. So in this study, we just focus on comparability of EHR system within a hospital. And in this study, we estimate differential EHR impact on patient safety depending on comparability of an EHR system within a hospital. And we use large patient administrative data and 15 types of AHR patient safety indicator with POA flag. And also, we address the endogenous absorption of EHR. And we used AHIT survey as a source of IT adoption, and HCUP data is source of our patient outcomes. And our study population includes adult surgery patient discharges in California, New York, and Florida during 2009 and 10. Primary outcome is a composite measure of hospital-acquired adverse safety event. So it's a binary variable, which is equal to 1 if any safety event are occurred during hospitalization. And key independent variables are two binary indicators, basic EHR use and interoperability of an EHR system. And interoperability is equal to 1 if an EHR system has a single vendor or hospital has a self-developed EHR system. And it is equal to 0 if it has multiple vendors. And here is a basic statistical model. So patient safety events are a function of interaction between basic EHR and interoperability and hospital area and patient characteristics. We use the linear probability model for the ease of interpreting interaction terms. We also estimate using a Login model, and results are similar to linear probability model. And in addition to attempt to deal with endogenous adoption of EHR, we estimate both the hospital random and fixed effect model. And here are key findings. Table 1 indicate almost 42% of adult surgery admission are in hospitals with basic EHRs, and almost 2% of adult surgery admission had at least one hospital-acquired patient safety event. And table 2 shows the differential estimate impact of EHR on interoperability. So simply it indicates that the basic EHRs with single vendor or self-developed EHR system reduce the probability of patient safety events, whereas the basic EHRs with multiple vendors increase the patient safety event during hospitalization. So here are conclusion and policy implication. First of all, only single source EHR system guaranteeing comparability or interoperability reduce patient safety event. And lastly, meaningful use of the EHRs with appropriate system are essential to achieve EHR benefits of improving healthcare quality and outcome. And I will start here.
Today I'm going to talk about the system engineering. We have proposed a framework where we can use a multi-criteria performance evaluation, and we are taking healthcare processes and we try to find out possible areas of solutions. Our disease that we are taking is diabetes. So as we know, that diabetes is a very expensive disease for our healthcare systems of the Western world. Counts almost for the 80% of the total expenditures. The main problem of the disease is not only the fact that you can die from diabetes, but the comorbidities that they are being developed through to this disease. And they have been developed a lot of simulations and a lot of models that they can predict through some clinical information, so your progression of this disease. And as I mentioned, there is the QT score from England, the DESIR from France. And we, as a system engineering, we are taking the advantage of the model-based systems descriptions. We try to link the different approaches and the different systems, and then through this integration, we will try to come outside with trade-off analysis. And we saw the importance of system engineering from the PCAST report, that we try to find solutions towards of high quality and lower cost that offers other industries that we have already from aerospace. So our methodology is using already working models like the Archimedes that has the advantage of object-oriented approach, the Michigan model that is very advanced in finding comorbidities, and UPKIP and the UKBTS, which is a British one, that is ideal one for generating risks. And we link actually all this analysis into one algorithm, and we will try to employ these models to make them some trade-offs. Our mathematical model that we will use here is the Markov chains. And the reason that we are using Markov chains is the compactness that offers this model, since it is very dynamic and also can source historical data with better visualization. So this is a first basic model where you can extract all this clinical information. Since this disease model is gender-based, we have different computations, and after the first decision node, we come outside to a second one that asks if we have symptoms that will trigger a second computation here that amplifies Michigan model here, which is, as we said before, essential for measuring comorbidity, complications of health. So we can go up to the lowest point and amplify a health process. This is a process that they are using usually for the retinopathy, and try to figure out in which severity already is the patient, based in the scale that they have discovered from Wisconsin. And this is our model of Markov chain. So in the upper part, you can see the states. These are the main states that we have from diabetes, that you are normal and you go pre-diabetic and then diabetic. In each transition point, you have probabilities of getting from the one state to the other. And the results, they could be or even probabilities or risk scales as they have been defined from medical associations or the ADA or whoever else wants to set up the scale. And as we know that every state triggers different tests or diagnostic tests, and every diagnostic test triggers as well different intervention for solving the problem that we have, and we try to solve the healthcare problem. And we are looping over the whole process, try to figure out what will be the influence of the intervention in every state. And again, we have a rearrangement of the probabilities. And given that for every point we are searching for the risks, the utilities, and the costs, we can combine all of them in a trade-off cost analysis, and we can try to implement different what-if scenarios. And if I would like to say something final about what is the importance of the model, is the integration, a framework-based, hierarchical component tracing, framework performance evaluation, and you don't give certain solutions, you just give framework to incorporate the complexity of the system.
My question is for Jay Yong. So when you are determining the interoperability, within the hospital, how would you determine or define the the systems are interoperable?
Okay. In this study, we just assume that that define that interoperability within the system, how that different EHR or health IT component within the same hospital connected and that work together. So our assumption is that if that hospital have like the single vendor, or they do have like the own developed system, it is more the comparable against that EHR system with the multiple vendors. That's how we define and assume that interoperability in our study.
Sorry, I have a follow-up question on that. Because there are so many components of the EMR systems, and maybe they don't have, some of them are self-developed or have the same vendor, but some other components, they're from other vendors. I mean, in that case, how would you, how would you measure that?
That is very good question. So, I mean, for the sake of our the data limitation, we just use the AHA survey as our EHR data source. I mean, it would be much better that we can look into detail about all the data, I mean, EHR component, but we couldn't, so we just use that number of the vendors as a proxy for the interoperability. But that is very good suggestion, and that for the future study, it is very worthwhile. I mean, that looking into that data detail. Thank you.
Any other questions on the first presentations? Okay, well, I have one for Amat. I thought it was very interesting on the adoption of home healthcare robots. So, and I guess my question comes more from a business perspective. So, what do you see as the trajectory of home healthcare robots entering home healthcare practice with potential prescriptions of home healthcare robots, or having a robotic dog running around the house barking at you when you need your prescription? I mean, what's your what's your take on that?
So good question. Actually, in our research, as I show, we focus on two kinds of robot, because I cannot focus on all the different kinds of home healthcare robot. The home healthcare robot can be used for different tasks: medication administration, medication management, sending alarm, monitoring personal health and safety, fall detection. There are different tasks, and in the paper we provided some tasks about the home healthcare robot. But in our research, we focus on two main tasks, like the robot that can be used to help facilitate the communication between the patient and medical professional, and the para robot, which is very helpful for people with cognitive disability. But the home healthcare robot could be used for tasks more than these two tasks.
Okay, thank you very much. And Yuzan, so your research on patient portals, I mean, this is a very big investment for a lot of healthcare systems in the country currently. So if I were a healthcare CIO tasked with purchasing and optimizing a patient portal, based upon your results, what would you say are some of the customizations, or how should I set up my patient portal to be most effective?
Well, to make it simple, you actually show more, not less. So our findings that showing comorbid alerts would actually prompt the patients to go and do the test, which reduces the time of what we call the closure alert time or closure time. So when it comes to design, I would suggest that if you're interested, or if there is a major alert or focal alert that you're interested in, you also show other alerts next to it or in the same page. And that's, from my understanding, not a lot of patient portals show all those alerts in one page. You might find them in multiple places.
Okay.
Again, my name is Kwei Du. I often go by Andy. So my topic is about parenting in the hospital industry. So first of all, that's a phenomenon. So a multi-hospital system, that's an organization which owns multiple hospitals in the industry, so more than one hospitals. In the past decade, we see more and more hospitals are now owned and controlled by a multi-hospital system, instead of being a standalone hospital. As of last year, about the percentage of hospitals affiliated with the hospital system is about slightly over 50%. So more than half of the hospitals are now controlled by a hospital system. And the question, of course, first of all, is why multi-hospital systems exist at all? Because each hospital can be self-sustained. having a multi-hospital system means another layer of administration, which creates bureaucratic cost. So there must be some benefits of having a multi-hospital system as a corporate parent, oversighting all the individual hospitals. The literature so far basically focuses on two mechanisms. One of them is economies of scale. That's very widely discussed. So the idea was, so multi-hospital systems, arguably, that's larger than the individual hospital. So because of the bigger size, there could be some efficiency benefits. There could be some more opportunities of learning, which leads to quality benefits. However, we do not really have a very strong empirical evidence to see having a larger size means scale advantage. So size does not automatically translate into a scale-based advantage. And the question really is, how can we actually make sure the size of a multi-hospital system can be turned into an advantage, scale-based advantage. And we are particularly interested in IT-based mechanism. So IT investment has this feature that you make one huge investment in the beginning, and it starts to be makes the firm operating more efficiently. So IT is kind of considered an important source of scale, economies of scale. So I have a quick chart comparison, so you can have answer to your mind which of these hospital systems can be a better parent. Just a little bit more detailed. So those are the IT landscapes of two multi-hospital systems. The columns are hospitals, so each hospital system has multiple hospitals, and the rows are different functions typically needed by a hospital, like patient registration or payroll or billing. And the color blocks are different software implemented in each hospital to support that function. So in the first hospital system, as you can see, each hospital kind of have its own standard. They made different IT investments for different functions. Well, for the second multi-hospital system, they have this standard approach, just one type of system supporting all the common functions, like Cerner for EHR system across all the member hospitals. By the way, this is a real-life example, not made up by us. So our hypothesis was if a multi-hospital can achieve the second scenario of this chart, it's going to be a better parent in the hospital industry. If there's another hospital either struggling or not, they want to find a corporate parent, it's better to join the second type of hospital system rather than the first one. We particularly look at two dimensions of this chart. The first one, I call it extensiveness. So if you look at the first chart, there are some blank cells there, meaning there's no IT system implemented in a particular hospital to support a particular function. By extensiveness, I'm trying to capture how many functions has been supported by IT system, in contrast to a manual process. And for the second dimension, I'm looking at the relatedness across the hospitals, meaning how related their IT investments are across different hospitals, so whether they are using the common system or not in their IT landscape. Our hypothesis are if a multi-hospital system, they can accomplish both extensiveness and relatedness in their entire IT landscape, they are going to reuse these IT resources to help their newly acquired hospitals, and which will consequently improve the newly acquired hospital's performance. And our research design is kind of difference in differences. It's not technically difference in differences, but that's the same logic. We have a set of hospitals acquired in year T, and we have another set of control hospitals are not acquired in year T. We have a performance difference, 3 years after and 1 year before the acquisition year. So the idea was if there's no acquisition happens to the first group of the hospitals, their performance difference should be similar to the second control group of hospitals. And the difference in these two differences can be attributed to the acquisition. So that's our measure on the acquisition effects. And that's going to be explained by the IT measures of the acquirer and determined by what's happening to the acquired hospitals during that acquisition implementation period. So I'm running out of time. So in short, I found supports from most of my hypotheses. So I look forward to your comments and the discussions. Thank you.
Super. So my name's Jennifer Goldsack. I'm a health services researcher at the Value Institute at Christiana Care Health System. The Value Institute's pretty new. It's an innovation center that's embedded in a regional health system. And I guess we're charged with bringing research expertise to a real-world setting and trying to provide instant feedback to some of our initiatives. Our health system, Christiana Care, is the setting for this particular study I'm going to share with you today. We're located in northern Delaware. We serve about 80% of the population of Delaware, for what that's worth. Some South Jersey, some Southeast Pennsylvania. Specifically today, we're looking at medical surgical units within our two hospitals. So we have a large suburban hospital in Newark, Delaware, and a smaller urban hospital in Wilmington, Delaware. So the purpose of this study is to look at the impact of health IT, and particularly EMR and CPOE, on staffing in the unit. And we were looking particularly at nurse extenders, so think your patient care techs, and unit administrators, so primarily unit clerks. But we didn't actually start out to ask that question. We were trying to come up with a better design for our discharge process. And we kind of made an assumption, which, as you know, in our line of work is always dangerous. We made an assumption that there must be some spare capacity in the two roles, so in the tech roles and in the unit administrator roles. And the reason we thought that is because, well, think about what happens when you have widespread IT implementation in any other industry, right? So you saw it, telecommunications, manufacturing, banking. You bring in those IT systems and you see a lot of displacement of those low-skilled workers. So we assumed that, because that happened in other industries, we expected to see it in our own. And similarly, we hadn't actually, as a health system, done any sort of purposeful redesign of our staffing model, having introduced EMR and subsequently CPOE, so we assumed that slack was still in the system. So we looked at the literature to see if there was anything out there to support that so we could crack on with our discharge study, and there was nothing at all out there, and we thought that this was important and worth looking into. We took a mixed methods approach to this. Our quantitative arm, we looked at our HR records. We had about 5 years in one particular software system, so that's all we had that we could, kind of match over time. We matched that with our patient census. So our primary data point was actually hours worked per patient day over a period of time. We looked at that in sort of 3 chunks. We had baseline, where we were where we were 100% paper hospital. We then introduced EMR, and then subsequently CPOE. So we had these 3 time periods. The qualitative piece, we performed structured interviews followed by focus groups with nurse managers who sort of owned the staffing process on each independent unit, and then the unit clerks themselves. So our finding, we looked at costs, and by using the HR data and our payroll data, we were able to look at costs, and we found that the introduction of EMR alone did not significantly impact staffing cost in any way, which is pretty much what we were expecting. But we saw that subsequent introduction of CPOE had actually really hugely significant impact on staffing costs at both of our hospitals. In terms of staffing itself, again, EMR, no significant impact on staffing, but CPOE had a significant impact on staffing overall. And remember, we were looking quite broadly at these, clinical support and at these unit administrators. And in that mix, we had unit clerks, we had our techs, our patient care techs, nurse extenders, and we also had, in our health system, we also have a blended role, which are individuals who are dual trained as unit clerks and as patient care technicians. So they're facile as administrators, but they're also confident going into a patient's room, for example, if the call bell goes off. They have that, tech training. And what we saw is, even though the introduction of CPOE reduced the support staffing overall, we actually did see a significant increase, a parallel increase in that blended role. So the remaining staff members, we were favoring that blended role of individuals who are, able to kind of drop back and manage different tasks on the unit. So that's what we saw as a result of the health IT coming in. So our conclusions, and this is kind of drawing on some of the qualitative results that I haven't had an opportunity to discuss today, But despite the reductions in costs and staffing following EMAR and then CPOE, we found substantial unused capacity still remained in the system. And what we found is a lot of that is due to core functions such as answering the phone that needs to be performed on the unit no matter what. And so our two main findings, I'll sum up really quick. Our two main findings are, first, is that this study provides perhaps the first evidence that one of the long-term goals of health IT, and that is that systems should experience reductions in payroll costs as efficiencies are achieved, may actually already be occurring in practice. But we also would conclude that the introduction of various health ITs should be accompanied by a purposeful redesign of administrative and clinical support. And then, of course, doing research is like playing whack-a-mole. Whenever you answer one question, you get another one. So our question is, and what we're actually looking into now is, has health IT, did these two technologies actually eliminate the work? Or, as we sort of fear, has it transferred it to more highly trained clinicians in the same unit? So that's our next question. Thank you very much.
First, I want to thank you for being here up to this time. I'm going to keep my presentation short. This is an early piece of work. The Victoria Kiseka is the PhD student who's working on this, and I'm representing her today. Professor Rao is in the MIS department. Shambhu is in computer science professor, and Gerber, Dr. Gerber works for the Roswell Park Cancer Research Institute in the disaster recovery team. Having said that, the question of resilience comes up quite often because you have various kinds of extreme events that affect a hospital, either the civil infrastructure outside the hospital or inside the hospital. Typically, when you look at an extreme event, we look at it as the failure of the hardware or the lighting. But most often these days, we have very good generators and backups in major hospitals. I'm not saying that story is complete with all hospitals, but oftentimes the communication infrastructure is affected, and in case of certain types of extreme events like the snowstorm, people don't show up to work, the technology works fine, and people with the right access are not at home. So then that leads to different kinds of practices. Now, this research looks at information systems from a people perspective because it is the people who are missing when there's an extreme event. Oftentimes, when a drill is planned, then people pre-print all the schedules and the patient data, whereas if there is an abrupt loss of power, then there is a loss in terms of how to proceed, and we are very ill prepared for it. So with that in view, we did this study. It's also premised on our other study, which found that about 6 to 7 months after an extreme event, like a hurricane or a snowstorm, those people who have experienced the snowstorm tend to take resilience for granted. And the very same people, when they are shown pictures and different interventions, change their view, because we did the survey before and after the intervention, and then we contrasted that with hospitals that had not experienced this, and our findings were very interesting, that some of the training impacts that have to be done with respect to people who have experienced an extreme event several months after that event also served as a motivation for this study. In this study, she's looking at what are the factors that influence the impression or the perceived hospital organizational resilience, and how has IS managed during an extreme event. And this is very important because perception of resilience is also based on the views of how the leadership is and how IT department has managed the processes that they have to manage prior to the extreme event. That forms negative opinion. So this study includes that aspect as well. From a methodological perspective, it follows a qualitative methodology at the outset and then goes to a factorial survey design kind of methodology at the end. So it's mixed methods in that sense. But even in the qualitative part, there are different stages. First, 6 top officials, COs, and CEOs were interviewed, and based on that interview, it kind of gave us some aspects of resilience that we should investigate. And based on that, we developed a script. And that script was then used to conduct focus groups. There were about 4 focus groups in different hospitals, and about a total of 23 participants, approximately 5 or 6 participants per group, to generate reasons of how to cope with an emergency and what are the factors that impact resilience. The focus groups lasted 30 to 40 minutes. They generated a number of ideas. And then we had several factors that we felt were very important, identified by the different groups. So we did a Delphi study, and the Delphi study allowed us to narrow the factors. And here are some of the factors that we found that were important. And then based on this result, and this is not a complete listing of it, we developed a survey, and we are looking at 30 hospitals in the New York, Western New York, and Central New York region, with about 25 responses from each of those, and the results are in the making. So it's still early for us to talk more about it at this time. Thank you.
So we know that for doctors, the most important signal of marketing is the word of mouth that they get from their patients. And in the offline setting, this translates into local diffusion, and it doesn't spread really fast. And it depends a lot on how good the patient is at spreading this information. But when it comes to the online form, it spreads really fast, and it depends a lot more on the platform on which the review or the rating is hosted. And there have been earlier studies that have seen the effect of online word of mouth on sales of other goods and services. So there has been empirical evidence that word of mouth increases sales of books, beers, movie, or games. So these studies are done already. But however, choosing a doctor is way different than choosing a movie, and there are significantly higher stakes on the part of the user. So online word of mouth is considered less credible as well, so that adds to the complexity, and the reviewers are anonymous and they are not known to the patient, so it's still a matter of debate. Would users take that anonymous signal into consideration and go for the doctor? So the research question we are looking at is, what is the relationship between the online word of mouth of physicians and the patient demand? So we get data from a website in India, which is the market leader in this space of booking appointments online, and that's how a profile of a doctor looks like on the website. And this website has more than 33% of registered practicing physicians in India registered, and they have a really high number of appointments per day, as 1,500, and very high daily traffic. And there are 25,000 plus active doctors, and these are the ones who get more than one appointment in the period that we are looking at. And the ratings are collected from over 35,000 patients. So we have a natural experiment set up, which is fairly clean. So outside of our control, this website decides to launch this feature of showing recommendations that it had collected over the period of last 2 months. And we try to find out the effect of visibility of these recommendations on the doctors that get these recommendations. So our treatment group is physicians whose recommendations are visible, and we construct a control group that's very close to it in terms of just not reaching the threshold of visibility. And we take a very small observation window of 3 weeks, 1 week prior to this and 2 weeks after this, to control for all other unobservable effects that we might not be able to control for. So we use a difference in difference approach, and we use a negative binomial fixed effect panel data model, and Our primary result is that there is a strong and significant effect for the doctors who get visibility on their appointments. And we redo this estimation for doctors who have much more recommendations visible than is the threshold cutoff limit. And we find that if you have much more recommendations, you get a greater surge in your demand. And we are looking forward to tease out the heterogeneity between different specialities and across different markets within India. So that's about it. Thank you.
Well, I'll start with one then. So Jennifer, so from the findings with implementing CPOE and EMAR together, so with those findings, if you were to sort of go through this implementation again, or as you expand these programs to additional hospitals within the Christiana Care Network, are there certain structural decisions you may make in how you set those up, or in terms of how you roll those out?
Yeah, so I mean, the key is going to be that applying these technologies can't come without any kind of purposeful redesign of the staffing model that they're supposed to work with. Like, if we think of it as more of a socio-technic system, we can't just add this technology and not address the issue of staffing and what that means. We're very fortunate, our women's and children's service line, our health system, actually was still 100% paper until spring of this year, and then implemented everything at once. So we have a sort of longitudinal study right now working, looking at not just the amount of work and the amount of staff, but actually potentially shifting work too. Because I think that's something that we need to better understand, I think, collectively, which is, that question that was outstanding, is work being taken away by these technologies, or is it simply being displaced? And I think that will inform the redesign.
Okay, great. Yes, there's a question in the back.
This question is for Jennifer also. I missed this, but are you distinguishing between headcount versus FTE? I guess in our own study that seemed like maybe people were actually just working different amount of hours rather than more people.
Yeah, that's a great question. So rather than looking at FTEs, we actually looked at number of hours worked. So we had just over 5 years of payroll data. So we had every hour, quite literally every hour worked. We also broke it down by, we could break it down by shift too. We didn't see any huge significant difference, but that was also important in terms of when we were looking at our costs of staffing also, because we could separate out time spent on the unit and then other time, for example, in training and vacation, that was adding to the cost burden, but that wasn't actually patient-facing. So, yeah, we looked at number of hours worked, which we were fortunate enough to have.